Tina Mody. She's going to speak about alternatives to opioid treatment. She's a pharmacist. And I'm going to turn this over to you. You can read a little bit more of her bio on the sheet that's in front of you.
Good evening, everyone. I don't know if you can hear me because I'm not very fond of mics. I might drop it. Okay, thank you. Thank you, Mary. So everyone, I'm a clinical pharmacist. My name is Tina. And today and that's perfect. You just brought up the topic that I'm going over today. It's going to be on non-opioid treatment for pain. And that's a great transition because you were on opioids for 36 years and you decided, hey, I'm just going to take acetaminophen because what am I going to do after 30 days? You're going to cut me off cold turkey anyway. So perfect transition. So here are some objectives that I'll be going over today. Opioids may not be a good option for chronic pain. And I think we've kind of addressed that, and I'll go on and explain what I mean by that. The next item on this agenda will be non-drug alternatives to opioid therapy. What other options are there if it's not opioids? And additionally, there's non-opioid medication alternatives. So there's your oral medications and there's also your topical medications. So why is opioid not a good idea for chronic pain management? And there's something called opioid tolerance or opioid-induced hyperalgesia. What happens is, I call this a double-edged sword. And I think Dr. Hoffman, Chuck had mentioned it earlier, that damn if you do and damn if you don't. Because what happens is when you're taking opioids for a long period of time, you may see it in this diagram. There's two different pathways that these medications go through. They go through the area where you're feeling the pain, which is the hand here, and also goes to your brain, which it might change some of the chemistries, the chemical properties in your brain, how you determine what pain is, what the signals are trying to tell you. And that's where we get into trouble. Because after taking it for a long time, what happens, your body gets used to this medication. It may not be as effective as it was initially. And it may create what we call tolerance, or it could also be something that you become, I don't want to use the word addicted, but you feel dependent on this medication, whether or not it's doing any good. And that's why, for a short course of treatment with opioids, it might be a good idea to help your body heal while your body's healing. But if you're taking it for a long time, your body may not respond as it should have been initially to this medication. So here, what the message that we're trying to convey is break the cycle, because pain is a cycle. No matter what we want to say about it, it goes from pain, muscle guarding, muscle spasm and inflammation, restricted movement, and that's where yoga really comes in also, muscle weakness, loss of normal function, and it just brings a lot of anger and frustration because you can't do the things that you would have normally done, and it just goes in the cycle until you break it somewhere along the pathway, whether it's through yoga, whether it's through alternative medicines that aren't opioid, or through physical therapy, which we'll go more into in this presentation tonight. So what are some non-pharmacologic alternatives to opioid therapy? So things that does not require taking of medications. And I just want to mention here, everything on this list is covered by your EOCCO. And that would include your physical therapy or occupational therapy, massage, acupuncture, cognitive behavior therapy, which we'll talk a little bit more about in the presentation tonight. And there's supervised exercise therapy by a licensed provider like aquatic therapy or yoga. And there's the intensive interdisciplinary rehabilitation. It essentially encompasses your cognitive therapist, your physician, your pain doctor, your physical therapy, and also maybe your clinical pharmacist or a case manager, everybody working together to help treat chronic pain. Because as Jordan, Dr. Graybill had mentioned, it's not just what's happened in the past is the physician would just treat the pain with medication. They'll just prescribe the pain medication and hope it goes away. But what we're realizing today is it's not really the medication that's helping treating the pain in the long run. You really need everybody, all hands on deck within the healthcare system to work together to help treat chronic pain. And that's what we're trying to convey today. So what my profession, I'm a clinical pharmacist, I'm going to talk about drugs. And I'm going to talk about drugs that aren't opioids. And here are some alternatives. You may be able to see it, but maybe you can see it on the handout. And as that gentleman over there mentioned, acetaminophen, Tylenol. That's a good alternative. And also there's your ibuprofen, also known as Motrin and Advil. And there's your naproxen, also known as Aleve. And there's also celecoxib, also known as Celebrex. Some other alternatives include gabapentin, also known as Neurontin. And then the same medication within that class is Lyrica, and I'll go a little bit more in depth about that. There's also the other medications that aren't traditionally used to treat pain is your tricyclic antidepressants or also your tetracyclic antidepressants. And I'll go into a little bit more detail next. So let's start with Tylenol. It's usually used for mild to moderate pain with Tylenol, also known as acetaminophen. What I really want to convey is with this medication, it comes in different strengths. There's your regular strength, there is your extra strength, and there's also an arthritis strength. And they're all really pretty much the same, but different in terms of how big of a dose you're taking. And the message that I'm trying to convey is make sure whatever Tylenol strength you're getting, make sure the dose, when you're taking it, no more than 1,000 milligram at one time. And whether that be your regular strength or your extra strength, which is about 500 milligram for extra strength, just make sure you do not take more than 1,000 milligram at one time. Okay? And the reason for that is it can increase the risk of liver injury if you're taking too much at once. And what I would recommend is make sure you do not take more than 4,000 milligram in a day. Okay? And be sure and just be cautious. As I mentioned, Tylenol, it's the go-to drug, especially children with fever, and it's in a lot of cold medicines. Especially during cold and flu seasons, it's in your sinus and cold medications. So when you're going to the pharmacy and you're going to pick up medication for a runny nose or a cough, be sure to go to the pharmacist there and just say, hey, I'm picking up this medication, I'm also taking Tylenol. Is there Tylenol in this medication, and how should I take it? Okay. So those are some things that I want to mention about Tylenol. The next drug is ibuprofen, and there's two different types of medications over the counter, and I'm sure everyone has seen it in their pharmacy, either Motrin or Advil. I can't say which one's better, but they work pretty much the same. What I do want to convey is the over-the-counter medication, there are about 200 milligrams of ibuprofen, and you can take it every 4 hours, or you can take the 2 tablets, and I usually don't recommend this because 400 milligram is the prescription strength, and I want to make sure your doctor is aware that you're taking that particular strength. It's 400 milligrams every 6 hours as needed, but just be sure, and there's a lot of numbers here, and I'm glad that you guys have the handout to take home too, because I don't want you to take more than 1,200 milligrams in a day, and that is over the counter. That's without your doctor's knowing. If your doctor has given you a prescription ibuprofen and they're telling you to take it differently, then I'll just go by what the doctor had told you. Some things I do want you to be aware of with ibuprofen, it's in the class of anti-inflammatories. So what I do want you to be aware of with this type of medication, you want to be sure to eat something first before taking it because it can upset your stomach. And if you have any history of stomach problems, just make sure you're letting your doctor know before you're taking it, and because that can make the stomach problem worse. And also, if you have any kidney problems or any heart problems, or if you're taking a blood thinner, or if you have bleeding problems, those are things that I want you to be cautious of with this type of medication. Make sure you let your doctor know. The next one, very similar, is called naproxen, also known as Aleve. It works pretty much the same way, but it just works, it tends to stay in your body a little bit longer, so you don't have to take it as frequently as you would have with ibuprofen. Okay. With this medication, over the counter, it's about 220 milligrams. You can take it every 8 or 12 hours. And the side effects, things to be cautious of, very similar to ibuprofen. Just make sure you eat something before taking it, and if you have any type of stomach problems, bleeding problems, kidney problems or heart problems, make sure you let your doctor know, or avoid this medication if you could. And the next one here, also within the same class of anti-inflammatories, but this medication is actually prescription. Celecoxib, also known as Celebrex. And something a little bit different about this medication is it doesn't cause a lot of stomach problems like the ibuprofen or the Aleve would. So if you have a lot of stomach problems, but ibuprofen or Aleve has been working really well for you, and you want to go with something that is associated with reducing inflammation in your body, muscle pain and such, this would be a good option. However, for the EOCCO to pay for this medication, here's the caveat. You have to try and fail at least 2 different anti-inflammatories, whether it be ibuprofen, naproxen, or meloxicam. And just to let you know, it doesn't have to be prescription strength. If you've tried something over the counter, you let your doctor know, hey, this medication may work for me. I've already tried these over the counter. Your doctor can let the EOCCO know, and this medication could be approved. But just like any other anti-inflammatory, I do want to mention that if you are allergic to sulfur medications, just be wary of it. And if you're not sure, then I would suggest, if you're it really depends on how allergic you are to sulfur. If, say, you've taken an aspirin and you haven't had a reaction, then you most likely may not be allergic to this medication, and that goes with all anti-inflammatories. And I always say to my patients, sometimes they have sulfur in dry fruits, and if you're not allergic to dry fruits, you may not be allergic to this medication, so you have to gauge. The next drug that I want to go over is called gabapentin, also known as Neurontin. And with this medication, it's not traditionally used for pain. It's actually used for seizures. But what we found in a lot of research and studies that this medication is actually really effective for nerve pain. And I would recommend using this medication if, let's talk about a little bit of the considerations with this medication. With nerve pain, and I have to put this caveat out there, and it has to be nerve pain that is covered by the EOCCO. It has to be on the covered line and not below the covered line for this medication to be covered by the insurance company. Some side effects with this medication is sedation and dizziness, and I always recommend, if you're starting off with this medication, your doctor did prescribe it to you, you might want to try it in the evening before going to bed, just because you don't know how it may affect you. It may make you really drowsy, and I definitely don't want anybody, when they're starting this medication, to start driving until you see how it affects you. So with that said, this medication, I can't really say what dose your doctor will put you on, because ultimately it really is it starts at a very low dose, and then your doctor may increase the dose based on how that pain is reduced with this medication. But again, something I do want to caution people about is if you have any kidney problems, your doctor might want to adjust the dose. So just be sure, if your doctor isn't aware of it, make sure you let your doctor know. And lastly, I do want to just talk about Lyrica briefly. Lyrica is in the same family as gabapentin and works very similarly, but for this medication, it is only indicated for patients with seizures. That's when it will be covered by the insurance, or if you have diabetic polyneuropathy, this medication will be covered. Otherwise, gabapentin is actually a really good medication for nerve pains. The next item that I want to talk about, tricyclic antidepressants. So why do we want to give antidepressants to treat pain? And Dr. Graybill did mention earlier that a lot of it with antidepressants, it's not that it's treating the depression, but a lot of it has to do with, it's not on your head, but oftentimes when patients have taken pain medications for a long time, the way that they react to pain is very different. And this particular medication tends to calm down the sensitivity level to signals that's associated with pain. And there has been research that has shown that this class of medication helps reduce nerve pain or even some lower back pain. And some of the drugs in this class I want to go over is amitriptyline, also known as Elavil, imipramine, also known as tofranil, nortriptyline, also known as Pamelor, and desipramine, also known as norpramine. And no, I will not be testing any of you on these medications. It's just giving you a list so that maybe, if it something that you've seen your doctor prescribe for you, you wouldn't be like, hey, wait a minute, I don't have depression. Why are you giving me this medication? So that's why. It can help relieve nerve pain. And again, with this medication, the dose is very different. It's very individualized. Everybody reacts to this medication very differently. It just depends on, we'll start you on a very low dose and see how that helps reduce the pain. It may go up. It can go up to 150 milligrams depending on which medication the doctor had prescribed for you. And the next thing here, so tetracyclic antidepressants. This particular class of medication is called trazodone that I want to touch on. And it's not specifically used to treat pain. It's oftentimes used to treat insomnia. Patients who go through chronic pain often have trouble sleeping. And this medication has been documented. It's worked really well for patients with chronic pain who has trouble sleeping. And essentially, it's a class on its own. It has been traditionally used to treat depression, but what we found with just patient cases that this medication works really well, especially when you're trying to get off of the opioids. This medication has worked really well to help you sleep at night. And the dose with this medication, again, it starts with a low dose, about 10 milligrams. You can go up to 200 milligrams depending on how much medication you need to help you sleep at night. And no, you do not, your body do not, and I do want to say with the tetracyclic antidepressants and the trazodone, you do not build tolerance to this medication. You do not get addicted to this medication. You can get off of it. And lastly here, I'm done with all the talks about oral medication. So today, I do want to give you other alternatives. If you don't want to take the medication, there's other alternatives topically. You can use something for inflammation if you have muscle pain. You can use diclofenac, also known as Voltaren gel. It's an anti-inflammatory gel that you can apply to the site. And with this medication, unfortunately, I do have to mention there is a caveat. You have to try and fail all the oral anti-inflammatories, or if your body doesn't tolerate it, if there's any reason why you can't take the oral anti-inflammatory, this medication will be covered. And another alternative is called the lidoderm patch, also known as lidocaine patch. With this medication is actually indicated for pain that's associated with shingles virus. If you've had the shingles virus, this medication will be covered if you've tried other agents that aren't as effective. However, if you do not have the shingles virus, it may not be covered with EOCCO. It's probably not going to be, but there are alternatives. And I'm not just leaving you dry without any alternatives. There's the lidocaine jelly. It works really well, although it doesn't stay on as well. You'll apply it more frequently, but it still works pretty effectively. However, I did see that over the counter they do have a lidocaine patch by Aspercreme, and it's actually the same. It's 4% 4% lidocaine in it. That it works exactly the same. You leave the patch on for 12 hours, and you take it off for 12 hours. And I do have to say that you do want to take it off and have that 12-hour of rest period from the patch, because you don't want your skin to, you want your skin to breathe, just so that you don't have any irritations to the site. But it works just as well, and you don't need a prescription for the Aspercreme lidocaine over the counter. Okay, and I do want to say there are options in opioids. I unfortunately have to say that with our history of understanding pain, we didn't understand pain very well, and the only thing we know is to stop the pain. And we tend not to want the patients to suffer from pain, so what we have done in the past is just give you a lot of pain medications to help control it, but not give you any alternatives. There are things over the counter that you can take that's safer, that you don't get addicted to, and that would probably be more beneficial for mild to moderate pain in the long run. So with that said, is there any questions for me tonight?
Yeah, the drug that you were saying to help people sleep when they're coming off the opioids.
Yeah.
You wouldn't want them to use that long term though, right? Because it stops the natural production of melatonin in the body.
I would not want them to use it long term, right? And then, as I mentioned, they can just get off of this medication. It's not something that they would constantly have to take more of or have that dependence, if you would.
And even with melatonin, if you take melatonin, it stops the natural production of your own melatonin as well.
Right.
Because I'm certified in yogic sleep,
Yeah.
so.
So ultimately, with any medication, we're just trying to get the body to the normal function so that they can get off of it eventually. And that is our hope until we learn more about chronic pain. There's always something to learn, and we're trying to get there.